Thank you so much for joining JOWMA tonight for our webinar on insomnia with Dr. Gary Lelonek and Dr. Elaine Boland. Just a little bit about JOWMA. The Jewish Orthodox Women's Medical Association is a dynamic organization of over 600 Jewish Orthodox women in medicine dedicated to professional growth, community service, and advocating healthcare knowledge. Through education, mentorship, and advocacy, JOWMA empowers its members and promotes health and well-being within our communities. Our vision is a Jewish community who has easy access to culturally sensitive and relevant health information and can make informed medical decisions. Thank you for joining us as we continue to support and inspire women in medicine. And for more health topics, check out our upcoming webinars and tune in weekly to the JOWMA podcast. Just for you all to know, no participants can see each other during this webinar. There will be time for questions at the end of the webinar, and questions should be submitted through the Q&A box, not the chat box, and will not be seen by other participants. So I want to just introduce our two wonderful speakers tonight. Dr. Gary Lelonek, MD, is a board-certified child, adolescent, and adult psychiatrist. He previously served for 10 years as a pediatric emergency psychiatry attending at Cohen Children's Medical Center and Long Island Jewish Medical Center within Northwell Health, and as an assistant professor of psychiatry at the Donald and Barbara Zucker School of Medicine at Hofstra. Dr. Lelonek currently maintains a private practice, practices as a child and adolescent psychiatrist at Premium Health Center, and serves on the medical advisory board of Amudim. Dr. Lelonek's lectures uniquely integrate contemporary child's mental health with Torah perspectives, exploring child development through the lens of Torah, and gives shiurim on tefillah and tehillim. Our other amazing speaker tonight, Dr. Boland, is a board-certified behavioral sleep medicine specialist and licensed psychologist. Prior to opening her private practice in early 2025, Dr. Boland was an assistant professor at the University of Pennsylvania Department of Psychiatry and clinical research psychologist at the Philadelphia VA Medical Center, where she conducted federally funded research on the links between sleep disruption and depression in older adults and women experiencing symptoms of perimenopause. She worked for over a decade for the Department of Veteran Affairs, providing behavioral sleep treatments to veterans with insomnia, and led nationwide trainings in behavioral sleep medicine. Dr. Boland has published over 40 journal articles and book chapters covering topics at the intersection of sleep and mental health. Currently, she maintains a private practice specializing in behavioral sleep medicine and provides workshops on lectures to mental health professionals and community members nationwide. Needless to say, both of these wonderful speakers are experts on the topic we are discussing, and with that in mind, I will let them get started.
All right, thank you so much, Julia. I'm going to try to share my screen if I can. Please let me know if you can't see that. But thank you all for having me here today. I'm really excited to talk to you all about psychological perspectives on insomnia and some of the behavioral treatments that we have available for treating sleepless nights. So I want to start by just having a quick overview on what actual healthy sleep looks like. I think it's good to understand what's going on when sleep is happening so that we have a better understanding, kind of mutual vocabulary for what we mean by sleep disturbance. So I want to start with just saying that sleep is a very active process. It's not something where, light goes out, you fall asleep, and your brain's just dead for 8 hours. It's a lot going on at night when we're sleeping, and there's different stages of sleep. The first stage is what we call non-REM stage 1. This is very light sleep. It's really the transition period between wakefulness and sleep. Lasts a very short time. Someone said your name, you'd pop up pretty quick. You're not very deeply sleeping at all. We transition then into a stage called stage 2 sleep. This is where we start to sleep a little bit more deeply. Our heart rate starts to slow down a little bit. This is a stage of sleep that makes up a good proportion of our sleep, especially as we age. It's a stage of sleep that's associated with memory processing. There's unique little signatures that we see on EEGs when people are sleeping in this stage. The next stage is non-REM stage 3. This is that deep sleep that everybody really talks about, that really feels good when you get it. And this is the deepest. This is what we call slow wave sleep. If we were looking at your brain waves while you're sleeping during this stage, it'd be very slow oscillating rhythms. And then we have REM sleep, which might be the most well-known known stage of sleep. This is when you're doing a lot of your dreaming. It's when we see some rapid eye movements during this stage. And so your brain is cycling through these different stages of sleep several times throughout the night. What you're seeing here is something called a hypnogram. So this is just a way of mapping out different stages across the night. And what you might see if we look up here in this young adult hypnogram is that there's different proportions of different stages of sleep, which might explain why we wake up at certain times in the middle of the night more often than others. So you might see that the proportion of deep sleep that we have happens earlier in the night. So when you're getting a lot of that good restorative sleep, it's usually happening in those first 4 hours or so. As we transition through the night, that's when you start to get more of that REM sleep. So you do more of your dreaming in the latter half of the night. Sort of geographically, for lack of a better word, REM sleep is fairly close to the awake state. So it's quite normal to kind of wake up from a dream. We're not too far from that awake state. The reason why I wanted to show this graph is because there is some change in what our sleep looks like as we age. And I say this to sort of normalize a little bit some of the awakenings that can actually start to feel bothersome as we age, if only because we don't expect them and we start to see them as not normal when they actually might be. So as we start to get older, this older adult hymnogram down here, when I start to say older adult, I would say maybe in the 50s and 60s is when we start to see these developmental changes. But the sleep gets a little bit more choppy. It's more likely that you'll have more awakenings. You might see a decrease in the total percentage of that deep sleep. So it's true that we're not sleeping as deeply as we age as we used to when we were younger. That's not necessarily a sign of a problem. But it just is more likely that we do wake up. And I want to really hit home, especially since we're going to spend some time talking about insomnia, that some waking up in the middle of the night can be normal, right? So waking up to use the restroom can be totally normal. Waking up, feeling a little disoriented, turning over and falling back to sleep can certainly be a part of normal, healthy sleep, especially as we age. But we'll talk in a little bit about what kind of awakenings in the middle of the night might not be so normal and talk about ways that we can treat that. Why is this not advancing? There we go. Okay. And just to give a quick overview of how the body keeps us asleep, I think can be really helpful. So there's two processes that are operating in the body when sleep is happening. One is called your homeostatic pressure or your sleep drive. This figure here is a woman blowing up a big balloon. We like to think of an analogy of an empty balloon that starts first thing in the morning after someone's had a good 7 or 8 hours of sleep. And as the day goes on, it's like that balloon fills and fills and fills with this pressure to sleep. So basically, the longer we go since the last time we slept, it's this steady build of that sleep pressure, that sleep drive. It works a lot like hunger. The farther you go from the last time you ate, the hungrier you're going to be. But that's not the only process that keeps us asleep. If we think about how we eat, for example, we eat something and then 3 or 4 hours later, maybe we're hungry again. We'll have another snack or we'll have a meal. If this sleep drive was the only thing that worked to keep us sleeping regularly, then we'd probably be sleeping in chunks, right? We'd sleep a little bit, be up for 3 or 4 hours, sleep again for a little nap, then be up. The reason that we don't sleep in that way, the reason that we're awake for extended period of time during the day and asleep at night has a lot to do with this circadian rhythm. So we all have a master clock, a biological clock that's in our brain. It keeps everything in our body running on roughly a 24-hour cycle. And so this is just what you're seeing here. This is a plot of your core body temperature. The rhythm of alertness that works with sleep follows that core body temperature rhythm pretty closely. So we start to see a little bit of a decrease in our core body temperature around the time that that alertness signal starts dipping, and we start to see an increase in our body temperature before we wake around the same time that that alertness signal is increasing. So I like to talk about it with my own patients as though, imagine you had a tiny little trumpet that was blaring in your ear, right? Even if you've built up a lot of that sleep pressure during the day, you're not going to be able to fall asleep if you got some trumpet blasting in your ear, right? So essentially, we're getting that consistent alertness rhythm during the day, keeping us awake while that sleep pressure is building. And at night, you can kind of see if those two things are synchronized, right? If our sleep pressure gets really, really full around the same time that that alertness signal is decreasing, then we're going to have a real easy time falling asleep. So those two systems work together. And I'll talk a little bit about that sleep drive some more when we talk about how do we treat insomnia in just a few minutes. We get a lot of questions about, well, how much sleep do we actually need? And I think we probably hear a lot in the literature about, 8 hours. It seems to be a magic number, 8 hours of sleep, 8 glasses of water. But there's actually a range, right? A lot of us are really different. The National Sleep Foundation puts it in about a 7 to 9 hour range for adults. You see here that deeper yellow is kind of like the ideal recommended range, but like any kind of normal distribution, there's going to be some people on the extreme. So there's going to be people who maybe need a little bit more than 9 hours, and that's going to by and large be biologically determined. There are people that don't need 7. They might get by fine on 6. I will say that what are genetically short sleepers, right? People who have their whole lives really not needed a lot of sleep. There tends to run in families. There's far fewer people that are genetically short sleepers than people who feel like they can just eke by on 6 hours of sleep. There's a lot of cultural pressure, I think, for people to almost wear it like a badge of honor for getting through weeks and weeks without much sleep. So you can certainly condition yourself to get by on less sleep, but the number of people in the world that only need less sleep is much smaller in comparison. All right, so we've set the stage hopefully a little bit for what normal sleep is like. Let's talk about what is actually going on with insomnia. So insomnia is diagnosed as a difficulty initiating or maintaining sleep. What we see here is an onset latency. That's the amount of time it takes to fall asleep at the beginning of the night of about 30 minutes or more. WASO, or wake after sleep onset, of greater than 30 minutes, or EMA, or early morning awakening, of greater than 30 minutes. So this can occur as just one symptom. You could just have a hard time falling asleep, but once you're asleep, you're fine. You could fall asleep fine, but then just have a hard time staying asleep. You wake up multiple times throughout the night. You have a hard time falling back to sleep. Or it could also be that you wake up early in the morning, much earlier than you want to be able to get to sleep. So it can be any of those or a combination, and it's associated with daytime consequences. So it's not just not sleeping well at night, it's associated with irritability, with fatigue, with difficulty concentrating, a lot of worry about not sleeping, worrying about how you're going to function the next day. And a lot of folks have this, what we call wired but tired feeling that is very difficult to deal with. And it's this sensation of, well, I feel really sleepy. I feel tired in my body, but it's like I can't shut my mind down. And that's something that can absolutely interfere with sleep, and is something we see quite often in individuals with insomnia. And I think it's helpful to talk a little bit of just how we think insomnia develops, right? Because insomnia is not like a disease that you can catch. It's not like the flu. There's not like a risk factor of communicability in that way. We really think it develops often as a consequence of stress, right? So this is what we call the 3Ps model of insomnia. It's not a very creative name, but it's basically to represent that there are premorbid or predisposing factors, precipitating factors, and perpetuating factors of insomnia. So premorbid, these are the things that you're born with, right? So we know that there's some risk factors for insomnia, which can include, having a childhood maybe where you moved around a lot. Some people can be genetically predisposed. There's no gene necessarily for insomnia, but there's little snips of genes that we know are connected to insomnia. So if you have a lot of people in your family that have a hard time sleeping, sometimes that can make you a little bit more likely. Being characterologically a worrier or someone who thinks a lot of really conscientious people. There's a lot of really great characteristics that also unfortunately go along with maybe having a higher risk of developing insomnia. So if you look at this schematic here and you look at the line that goes, think of that as a threshold, right? So everything below that threshold, we're not really considering that to be problematic. Above that threshold, we consider that to be insomnia. So depending on how many of these predisposing factors you might have, it might not take too much stress necessarily to put you over that threshold line. what we see in the acute phase when someone first starts to have sleep problems is that they're usually something called a precipitating factor. This is usually a stressor of some kind, and it doesn't have to be something bad. It could be something great, like an upcoming wedding or childbirth or a new job. But quite often, it's also something stressful like moving or divorce at the end of a relationship or a death in the family, right? It's very normal for sleep to be something that gets disturbed when there's stress. We are evolutionarily designed for that to be the response. And so what happens in the early phase is that a lot of the reason that you're not sleeping is due to the actual stressor, right? It's due to the circumstances. It's due to not being able to get to bed regularly. It's due to a lot of worry. As the stressor starts to move away, as we start to recover from whatever had started the initial sleep disturbance, what tends to happen is the thing that is maintaining the insomnia is what we call these perpetuating factors, right? That orange block there. And these are the behaviors and the thinking patterns that linger even after the stressor has gone away. So these are things like a lot of times when people are struggling to fall asleep, they think, well, maybe I need to get into bed earlier, right? I need to start trying to sleep sooner. And they start to actually put a lot of effort into trying to sleep. So sleep extension is something that can actually make sleep harder. Worrying about sleep, associating the bed with a lot of worry and concern can be something that kind of keeps that insomnia going. So we also think that it's really these perpetuating factors that if we can address those behaviorally, we can really help the individual start to get some better sleep. And I just want to point this out too, because not everything is insomnia. We do talk a lot, and we're going to talk a bit today about just insomnia in general, but sometimes it can just be a little bit of a mismatch or a misalignment of the circadian clock. I think Dr. Lelonek might be talking a little bit more about melatonin and some of these circadian pieces. I won't go into too much detail there, but essentially what's happening is your clock, your internal clock could be shifted a little bit. You might be someone who's known as a night owl. And that's not just because you like the nighttime. Your body might actually be giving you signals to go to bed much later. So when you're trying to fall asleep at an earlier time because it's the time that you think you should be trying to fall asleep, that can masquerade as insomnia when really you don't have a sleeping problem due to worry and other reasons. It's just because your clock is shifted a little bit. Same thing, if you're a morning lark, right, you might be waking up much earlier than you want to, just because that's when your alertness signal is piping up. So in behavioral sleep treatment, excuse me, we do a lot of assessment around, is it insomnia or might it also be a circadian issue of some kind? And I'll just take 1 second here just to talk briefly about sleep trackers. So that is one thing that can also contribute to insomnia. We live in a great period in medical science now where a lot of people are caring more and more about their sleep. We're really hearing in the public media just about how important it is to get sleep. But what we find is that sometimes it can make people so anxious about their sleep that they start to worry about the actual healthy sleep that they're getting, and that can cause some sleep problems. So I think that there's been a recent study, I should have cited it here, from the American Academy of Sleep Medicine showing that I think with the rise of these sleep trackers, there's been like a 70 some odd % increase in sleep anxiety as well. It's important to know that these sleep trackers are just estimating your sleep. They're really not, research grade, solid gold understandings of how you're sleeping at night. And they have actually not been normed or tested quite frequently on individuals who have sleep problems. So they tend to be better at gauging sleep in people who already sleep well. So if you're someone who doesn't sleep well, you have to kind of bear in mind that this might actually not be capturing your sleep well, and then contributing to some more sleep anxiety. If there's time later, I'm happy to talk more about some of these sleep trackers if there's questions. But before my time is up, I just want to talk about, well, how do we treat insomnia, right? And so the gold standard therapy for insomnia from a behavioral perspective is what's called cognitive behavioral therapy for insomnia, or CBT-I. And it consists of 3 main components. The first is behavioral. This is a combination of what we call stimulus control and then time in bed restriction. And these targets excessive time in bed, so people who are getting into bed way too early, spending too much time trying to sleep, It combats the irregular sleep schedules that we see as a way to try to strengthen and regularize that sleep drive. It addresses the cognitive component of insomnia. So there's a lot of unrealistic sleep expectations that can come along with insomnia, misconceptions about sleep, anxiety about sleep. So we teach a lot of, relaxation strategies and working on those cognitive components. And then just some education around sleep hygiene and how to make sure the environment is conducive. And when we say stimulus control, just to give you a brief understanding of that, this is very Pavlovian, right? So essentially what's happening is called conditioned hyperarousal, right? So think of Pavlov and his dog, right? So this was a Russian scientist. He trained his dog to salivate to a bell by continually pairing a bell and steak, right? So every time the dog smelled steak, he would start to salivate. Every time he smelled steak, he heard the bell to the point where he could just hear a bell and start salivating because that dog started to learn, oh, that bell means that I'm going to get some steak. What happens with insomnia is the bed becomes a bell for anxiety and frustration, right? The longer you spend in bed trying to sleep, tossing and turning, looking at the ceiling, thinking, I'm never going to fall asleep, the more the bed becomes associated with that practice. So stimulus control is really trying to unlearn that association. So we want to break the association that comes with spending a lot of time in bed. So what we will do is tell you, when to get into bed, when to get out, so that we have a good anchored rhythm, making sure that you're not spending unnecessary time in bed. And also what to do when you're not sleeping, right? Focusing on relaxation, making sure that you're not pacing around the house, trying to, work and do things that are not conducive to sleep. Time in bed restriction is a component that tries to help build up sleep drive. So what we do is we have some good daily diaries that we get to get a good night-to-night assessment of what your sleep is like. And then we actually limit your time in bed, not to a huge degree, but we try to combat the fact that people will spend more time in bed trying to sleep. So we actually try to cut off that attempt to try to fall asleep. And then we monitor how a person's sleep efficiency is. So sleep efficiency is just, okay, well, of the time that you're spending in bed, how much of that is actually sleeping? And so we monitor to make sure that we're getting a good sleep efficiency, and we start to add some of that time back. There is, the caveat that sometimes this therapy, this specific component of the therapy can, temporarily increase your sleepiness early on. So that's something I always want to make sure people understand. Like, this can make you feel a little bit worse before it gets better, but it's kind of a short-term gain, short-term pain, long-term gain kind of situation. So it really shouldn't be used as a self-help tool. As much as I'm talking about some of these things, this is just to give you an overview and not to have you try it on yourself, because there's a lot of things that we do take into account when we're putting some of these strategies together. When it comes to cognitive arousal, we will address pre-sleep anticipatory anxiety, the negative emotions that you have about sleep, intrusive thoughts that you might have in bed, catastrophizing at night about potential negative consequences of poor sleep. Like, oh, if I don't get to sleep tonight, I'm not going to be able to function tomorrow. How am I going to drive? And it's actually that process of worrying that's lighting up all of the hyperarousal systems in your brain, making it even harder to actually go to sleep. So we've tried to target that arousal at night to help you be able to fall asleep better. And so we do things like cognitive restructuring of some of these negative beliefs, helping you come to kind of a more rational understanding of how sleep works. We do things called scheduled worry time. And then I also like to integrate some acceptance and commitment therapy techniques in here. And then just a word about sleep hygiene. Also want to make sure that, your environment is good, that the light is good, the temperature is okay, that you're not exercising right before bed, that you're not smoking a cigarette right before bed. But sleep hygiene in and of itself is really not sufficient. Actually, in the clinical trials of insomnia, it's used as a control therapy, right? So sleep hygiene is important and helpful, but not a standalone treatment. So it was very fast. I just have one slide here about how CBT-I works. I want to make sure there's enough time for Gary to be able to talk about the medication components. But CBT-I has been shown to be as effective as sedative hypnotics during the first 4 to 8 weeks of treatment, but actually more effective longer term. So more than 3 months after treatment, the people who go through CBT-I tend to have longer effects because they're learning new strategies, right? A lot of times, and I'm not anti-medication by any means, but an unfortunate component of medication is that when you stop taking it, sometimes the symptoms can come back. So we do see a persistence of some of these effects, up to a year later. And typically the response rate we see is that about 50% improvement in symptoms can be kind of expected by the end of treatment. So if it was taking an hour to fall asleep, then it's typical for it to, whittle down to 30 minutes or so. But then we tend to see continued improvement even after treatment ends. And so what this has resulted in, the American College of Physicians actually recommends CBT-I as a first-line treatment for insomnia. Not everyone, however, is going to respond, right? So I think the clinical trials say something about 80% or more tend to respond. So that does mean, unfortunately, that there are going to be people for whom CBT-I is not the ideal treatment. And in that case, medications where I think can and should be a part of the treatment offerings for people whose insomnia doesn't seem to remit. So with that, I want to pass the torch over to Gary, who will talk about what some other options are for treating sleep. And hopefully I didn't take up too much time.
Hello, everybody. I'm going to share my screen now. Okay. Excellent. So, thank you, Dr. Boland. It was, I thank you. It was a great presentation. And you stole some of my thunder in terms of CBT-I is definitely the first line treatment, and medications are really used as a band-aid because medications, by definition, are only useful when they're being taken. And so if you ever want to be off with medicine, you really need to learn the skills that are necessary to address those predisposing factors that sort of created that situation. And medication has a much higher relapse rate than CBT-I. Yet, of course, here I am talking about medicine. I'm a psychiatrist, so here we go. So it's fascinating that, I like to bring always a background of the Torah, what the Torah says about certain ideas. So even though Achashverosh in the Megillah does not have insomnia, we do have a sense that there was something on his mind. And so it says at a turning point in the Megillah, it says, Balayla hahu nidada shnas melech. And the nidada means to flee. It's a lashon of nida, like it's a flow. It was escaping him. It was running away from him. And this was something that, a lot of people, when they have insomnia, they just watch the clock pass them by and they are chasing after sleep, but sleep is just out of their grasp. It's really fleeing from them. And so that's something that comes up. And so Chazal were very aware of, the need for sleeps and the importance of sleeps. And we actually have a tefillah that's created about sleep. Now, it's a tefillah, a Kriya Shema Lamita, Hamapil. And interestingly, Hamapil actually comes from Mishlei and Tehillim. It comes from Mishlei, it was written by Shlomo Melech. So Shlomo Melech says, don't give in to sleep. Don't give yourself sleep to your eyes and, slumber to your eyelids. And David HaMelech, when he's searching for the place where he's going to build a base of Mikdash, he says, I will not give sleep to my eyes until I find it. Okay. And then we have a whole tefillah that really talks about having a peace of mind and being recharged and feeling rested and not to have bad dreams. Like a lot of the things that do contribute to insomnia and sleep problems are part of this tefillah. And interestingly, the Abu Hadram and Rabbi Yehuda ben Yakar, Rabbi Yehuda ben Yakar lived in Spain in the 1200s. Abu Hadram lived in the 1300s. Tell us that the words hamapil chavlei has nothing to do with being bound up by rope, but it's actually about being given. Hamapil chavlei is the way that the Torah uses to describe the the division of the land of Israel by Yehoshua, that it was a divine allotment that was being given. And so the Abuda Drum and Rabbi Yehuda ben Yaakov say it actually comes from Tehillim, not Yud Chet, actually, that was my mistake. It came from Tehillim Tet Zayin, and that it's all about, if you look at what's going on in this Tehillim, we started out with saying Hashem menat chalki. Hashem is my portion, and he's my cup. Chavelim nafalu li b'ni'imim. He gives me a beautiful portion. Af nachalas shapara lai, that he's going to support me. And then we say avarechet Hashem asher ya'atzni. I'm going to give a bracha to God who has given me a advice. Af leilot yisruni kilosai. Even at night, yisruni is to be like tormented. Is talking about that even at night when I'm being tormented, Hashem is giving me an allotment. And so he says, Shifti Hashem lenegdi tamid. Hashem is with me always. Ki mimini balamot. He won't let me. Fall. And so this is actually the source of Hamapil, and we get a sense that sleep is a divine allotment. And even David HaMelech and Shlomo HaMelech, when they talk about sleep, they talk about not giving themselves sleep. So sleep is truly a gift, but it's an allotment. And just like whether you had the inheritance of Israel, not everybody got the same allotment. Some got bigger pieces and some got smaller pieces. Same thing with sleep. Sleep is going to be individualized, and it's individualized from Hashem. Okay. And of course, we do know that day is the smallest unit of renewal. Night, if you do not have if you cannot have night before, you need night to be refreshed for the day. And so, of course, we say in the Jewish calendar that night precedes the day. And that's what we definitely see, that sleep is the recharge for the body. And we see that this is even in plant life and animal life, that the plants need the nighttime and animals in the need the nighttime, to the point actually that melatonin is also created by plants. And some of the melatonin that you can buy, actually is plant melatonin. So this is something that's not just about humans. Okay, so what goes into our circadian rhythms? So here you have different hormones that are going to be, modulating the sleep cycles, and melatonin is is this curve right over here, and then it rises, during the day, before you're going to bed, and then you have testosterone, you have growth hormone. And so that these are all hormones that are going to be involved in helping us maintain our sleep cycle. Okay, so why is growth hormone important? So in terms of and how does it affect sleep? So when sleep is restricted, the main post-sleep onset of growth hormone is reduced. And this can also be compensated by increased growth hormone secretion during the day. But after a large increase in growth hormone is consistently observed shortly after sleep begins, typically during the first deep, slow wave sleep stage. So these are, especially when you're talking about kids, there's a tight integration of how growth hormone works connected to our kids growing. That's why we've always told our kids, hey, if you want to be nice and tall or reach your maximal height, you need to get a good night's sleep. Okay, and so this is somewhat what Dr. Boland had talked about, that there is recommendations of what we expect the range of sleep for adults and kids. Okay, and that during different parts of our as we age, our melatonin, which is really one of the main hormones that are in charge of the circadian rhythm. So melatonin secretion decreases in age, and it's actually one of the reasons is that melatonin is there's a couple of places in the body where melatonin is created. One is in the GI tract, where it's involved in immune response, and also in the brain, the pineal gland. And the pineal gland actually calcifies as we get older. So you can imagine that if something's getting calcified, therefore, it's not going to be secreting as much melatonin as it used to. And so that's going to therefore decrease melatonin as we get older. And that sleep disorders affect nearly half of adults over 65, impairing life quality, cognitive decline, mood disorders, and metabolic syndrome. Sleep is involved in the homeostasis of the body and helping the body stay healthy. Um, and we do know that with worse sleep, with insomnia, there's higher rates of depression and in fact suicidality. Menopause also causes sleep changes, fragmentation of sleep. Lower estrogen causes poor temperature regulation in the hypothalamus. And we all have known women who will say that they can't sleep because they're so hot, they're so cold. The temperature regulation really deeply affects their sleep. And also it affects the other hormones that are being secreted. And less progesterone, which decreases GABA. GABA is a relaxing hormone, and less melatonin. Okay. And of course, treatment of menopause oftentimes includes hormone replacement treatment or sleep apnea treatment to help, women be able to sleep better. A sleep mask and CBT-I are going to be one of the main, interventions for insomnia during this time period. And then melatonin, especially an extended release melatonin, 2 hours before bed, most closely replicates the body's own melatonin curve. Okay, what about kids? Okay, so right now we are going through the great sleep recession, changes in sleep that the kids in general are getting less than 7 hours of sleep. Girls are getting less sleep than boys. And here we see just a comparison. On the right-hand side, you'll see that the decades of 91, the years of 1991 to 1995 is the top curve, and the bottom curve is the most recent of 2011, 2012. And we're just really seeing a decrease of sleep for adolescents over the last 30 years. And so this is affecting not only adolescents, but middle school kids are also experiencing less sleep. And we know that there's an increased risk of suicide when kids are getting less sleep or having insomnia, and that if we are able to help them get for every 1 hour more of sleep, we see an 11% decrease in suicidal ideation for kids who are having depression and having suicidal thoughts. There's less automobile accidents, less cognitive issues when kids are getting better sleep. And interestingly, when you have poor sleep, it mimics a lot of different psychiatric conditions. And so you can have depression can have poor sleep. Anxiety can have poor sleep. Bipolar can have less sleep. Schizophrenia can have less sleep. ADHD, you can have a lot of types of ADHD types behaviors when a kid gets less sleep. So less sleep is really about homeostasis and about overall body health. And we do know that sleep affects kids with autism. And actually, this is a great study about prolonged release melatonin. But interestingly, in addition to helping the kids with autism have better sleep and less agitation, caregiver quality of life improved as well, with 49% of caregivers experiencing an improvement in the quality of their life once their kids with autism were getting better sleep. Okay. And this sort of leads into the current concern of melatonin and the safety of melatonin. And what do we consider long-term use of melatonin? What's considered short-term use of melatonin? And there's just hasn't been a great amount of research about the long-term effects of melatonin. And so this is something that there was recently the American Heart Association put out a bulletin from a poster that they presented about the long-term negative effects of long-term use of melatonin. And these are people that have been using it for years upon years, if not decades. And so those results definitely showed that there was an increased risk of heart events, when people were taking melatonin long-term. And we're going to get into that. But here, this study was really showing that after 2 years of these kids with autism taking a sustained release melatonin, that they didn't appreciate any negative side effects from the 2 years of using melatonin for kids with autism. So when someone comes, to a psychiatrist or to their medical doctor for help with insomnia, there's, what's something in medicine, there's always something called a logarithm. In other words, it's just what is my plan of action? What is the best way to handle this? So the first thing we always try to do is to find out, is there an underlying medical reason for the person to have insomnia? And if we want to go back to the American Heart Association's discussion of long-term use of melatonin, people are self-prescribing and self-treating themselves for a sleep issue. The question is, why do they have that sleep issue to begin with? While melatonin has helped them get sleep, but it hasn't addressed the underlying issue. So that includes a medical workup and a psychiatric workup. And one of the most common things to be done is to get a sleep study. And from the sleep study, we can understand if someone has sleep apnea, which can be a cause of all sorts of medical issues. In general, magnesium and L-theanine are very good supplements to support regular body health and for sleep. And then the next thing would be CBT-I, sleep hygiene. And then at the last resort, really should be medication. And medication for insomnia should always be tried first to be a short-term intervention, less than 3 months. And even if that's not enough to help a person, then they should, if they haven't gone to CBT-I, they should definitely try the CBT-I if they didn't want to go initially. Okay. And then when it comes to choosing medications for insomnia, as a psychiatrist, I'm going to be looking about, as we talked about in the workup, if there is a psychiatric, condition that is contributing to the insomnia, like depression, then I'm going to be treating both the depression and then and the insomnia. And I'm first going to see if the depression treatment is going to be helpful enough to mitigate the insomnia. And then depending on the degree of the insomnia, I will work with the patient about adding other medications. And sometimes I can choose an antidepressant that has more sleep as a side effect, and so, PTSD with nightmares, then I might try prozaicin, which is a medication that's known to help with nightmares. And similarly, there's a lot of these medications that are listed next to their diagnosis. A lot of them are FDA approved as a treatment for, let's say, clonidine and guanfacine is FDA approved to be treating ADHD with a known side effect of sleepiness. And in fact, for kids with ADHD, a lot of psychiatrists will use clonidine or guanfacine, but clonidine actually has a stronger sleep effect on kids. They will use that instead of needing to prescribe or recommend melatonin. And that's something that melatonin, because it is a hormone and it has multiple uses in the body. Like we said, it's involved in immune response. So there's melatonin, we know that it's not just doing sleep. And because we do know now that there are multiple other body systems that are being involved, short-term use of melatonin can be safe. But like when it comes to a kid with ADHD, clonidine is a much better intervention because it's actually, it's a blood pressure medication that's being used that is known to have sleep as a side effect. Okay. And we'll skip that. So general rules of medications for insomnia is, like I said, limit the hypnotic use to 2 to 4 weeks when possible to prevent dependence. Expect 1 to 3 nights of rebound insomnia when discontinuing. Be aware of complex sleep behaviors sleep driving, sleep eating that occur with specifically benzodiazepines. Benzodiazepines are Klonopin, Xanax, or Z drugs, which and discontinue if these occur. And um, usually we try to not have it be a daily, thing. Try to use it 2 to 3 times a week, even if you're being prescribed it in general. Obviously, you're going to work together with your doctor to come up with the correct sleep plan for you. Okay. So melatonin here, so melatonin, let's just get into it because it's such a fascinating thing. It's something called a chronobiotic and a mild hypnotic. What's a chronobiotic? A chronobiotic is something that actually modifies your circadian rhythm. It's not actually trying to put you to sleep as much as it's telling your body to actually go to sleep. It's like it's a fine understanding of what we're talking about, but it's really just sleep pushing up your body's your internal clock if you're giving it at the right time. If you give it at the wrong time, it actually delays your body's internal clock. So it's all about figuring out when the right time to give melatonin. And melatonin is used for, it's great for jet lag. And here I mentioned Herbatonin Pro is a plant-based melatonin, which is extended release. It's KSA kosher, and it's been third-party validated to be actually have what it says it has. And what do I mean by that? So when you pick up melatonin, from your regular, vitamin shop, it's the FDA does not regulate vitamins. It does not regulate melatonin, and so it's not you never quite know exactly what you're getting, and unless you have something that is something called third-party tested supplement. A third-party tested supplement means that there's been another company that's come in and run it through their laboratory that whatever they say is in the product on the label is actually in the product. And so recently there was a published report and certain melatonin, vitamins had 800% the amount of melatonin that was said in there. Another melatonin product had serotonin in there. So you just, not to say that every single melatonin brand is bad, but at least when you get a third party tested melatonin, you know what you're getting. Okay, so here's probably among the most important slides I have. It's a little bit confusing, and I apologize. But essentially, it's something called the phase response curve for melatonin. And Dr. Boland had mentioned that some people have delayed phase of their sleep, and some people had advanced phase of their sleep. Delayed phase means that their phase of their circadian rhythm is happening, let's say, at 2 a.m. An advanced phase means it's happening earlier. Okay. And so what you want to do when you're shifting your circadian rhythm and you're trying to get to sleep earlier, you're trying to advance the phase of your sleep. Okay. So in here, anything that is on the top half of this slide advances the phase of sleep. And so the red curve is the melatonin curve, and the blue curve is light. Okay. Anything below the zero line delays sleep. Okay. So here you see that if a person's getting to sleep, in this case, it's at midnight. So if they wanted to advance the phase of their sleep using melatonin, it's ideally actually probably going to be giving them melatonin about 2 hours earlier and not a half hour before bed. If you go to a half hour before bed, it's only going to advance the phase of their sleep in a minor way. But if you're going to give it at least, an hour to 2 hours before, you're going to have a greater impact on the shifting of the circadian rhythm earlier. Now let's look at the light, because we all have our smartphones, and so we see that for a certain part of the day, the light is the blue curve. So for a certain part of the day, seeing light does not affect our phase of our sleep. But as we get towards, when its sun has set, then you see that there's a great impact of light on delaying the phase of sleep. And that when we talk about our teenagers having a delayed phase of their sleep, a lot of times it is connected to their phones, because when they're on their phones is delaying their circadian rhythm. Yet, we know that when you wake up, that's you see that all of a sudden around you know, uh, in the middle of the night, all of a sudden, if you start to you need light to wake up and to actually decrease melatonin, and so therefore, light in the morning is actually shown to help advance the phase of sleep. In other words, if I have a patient that has insomnia, I have them wake up and expose themselves to either daylight for an hour or that they will get a 10,000 lux light. And they can do that in the morning, and that will help shift their phase earlier for the next night. Okay. So it's a matter of choosing when you're going to be exposing to light and when you're going to be taking the melatonin in order to advance your circadian rhythm. Okay. So, and melatonin is a funny thing because people tend to think, oh, I need more melatonin to get better sleep. Not true. Melatonin is the body a lot of times sometimes needs micro amounts of certain vitamins in order to get the best effect. And melatonin is one of them, that even 0.3 milligrams of melatonin 2 hours before sleep will eventually help advance the phase of sleep because the body doesn't create 3 milligrams of melatonin. The body produces much smaller amounts of melatonin. So you're really trying to mimic the body's own melatonin secretion, and therefore smaller amounts of melatonin are actually more effective advancing the phase of sleep in order to help with insomnia. Okay. So here's the negative. We talked about negative effects. Essentially, we still need a lot more time to figure out the effects of melatonin long term. And the bottom line is that the best treatment really is CBT-I, and melatonin can be used in the short term primarily, unless you're directed by your doctor. Okay. Um, okay. So what are other medications that can be used? So Ramultan you can see the word melatonin is in there. So it's a very similar melatonin to melatonin. It's given at 8 milligrams. It's actually a generic now, so it's something that can be easily, it doesn't need a prior authorization, has a low risk for fall and does not have the same complex sleep behaviors as Ambien or other Z medications. And generally, in the geriatric population, melatonin is well tolerated and almost is ideal for adults with circadian rhythm disruptions if they're not going to be doing CBT-I. Ambien, is the vitamin A. These are Z drugs because they all have Z's in them. So they're at Lunesta, Sonata, and Ambien. And they're very good. Again, they can be used short term. Ambien is the one that a lot of us are familiar with. But they do cause a lot of next day sleepiness. And just in general, for people who don't want to have the next day sleepiness or waking up in the middle of the night, Xalapon or Sonata is a better option for any sort of middle of the night awakenings. But for the geriatric population, it's really a third line option because of the next day sedation, driving impairment, complex sleep behaviors, and geriatric population, it's always going to be lower dosing of medicines. Benadryl, another favorite of a lot of people. Really, Benadryl should not be the first line agent when it comes to sleeping, whether it's with kids, adults. Melatonin is still more appropriate for use, although Benadryl obviously is a lot of people have at home because Benadryl has a lot of other side effects. Benadryl is really discouraged for the elderly population because it causes urinary retention and also can cause cognitive, impairment. And so there's a Beers criteria, but it's basically it's discouraged for the geriatric population. Klonopin, Xanax, there's a lot of people that will use these medications, a lot of primary care doctors that will prescribe them. Klonopin and Xanax are addictive, and so I very infrequently use it, and I don't use them really for patients with, sleep issues. Although low doses of them, I know there are lots of doctors that will use them for in low dose. And again, in the geriatric population, this is a no-no. We don't really, it's discouraged to use benzos in the geriatric population because of the cognitive clouding, falls and fractures and sedation. Okay. Um, Dora, so not Dora, the Sleep Explorer. Dora are these are newer medications. Um, and so they are very good. There's a lot of promise for them. Um, and that it's here I wrote that there's a Sunrise trial in older adults that compared it to placebo and compared it to Ambien, and that they significantly improved sleep onset and maintenance, even in older adults. So this is more in the newer end of medications. Antidepressants can be used for their sleep effects. In general, trazodone, which is a very commonly used one, the American Academy of Sleep Medicine recommend against it for insomnia. I frequently will wind up prescribing doxepin, a low dose of doxepin for even kids with insomnia. 3 to 6 milligrams is usually considered a very low dose in terms of that you're really not getting an antidepressant effect. You're much more getting just a sleep effect. And mirtazapine is another medication. And again, this is another medication that lower doses are cause more sleep than higher doses. Seroquel is another medication that's used. It's a antipsychotic. It's a mood stabilizer. And again, in geriatric population, in general, we do not recommend using this for insomnia. It is used in the geriatric population for certain, in certain mood disorders or for schizophrenia or for, some agitation. But there's still a black box warning against use of antipsychotics in the geriatric population for agitation. And guanfacine and clonidine we talked about for kids. And everything that I shared with you is actually a lot of it comes from what we call the Carlat Psychiatry Carlat Report. It's not funded by, it's a publication that reviews medication that's not funded by the pharmaceutical company, so it's free from their influence. And the American Academy of Sleep Medicine, and that's it.
Okay, well, thank you so much to our wonderful presenters. As someone who struggles with sleep myself, I know that I definitely learned a lot. Just in the interest of time, because we're moving to the Q&A portion, we're just going to stick to a couple of questions. Starting with, why do people feel so tired after eating? And is it advisable to go to sleep shortly after a meal? And I'll just open the floor to answers.
I'll just from a general sleep hygiene perspective, we do know that a heavy meal before bed can sometimes get in the way of sleep, just if it's kind of sitting in your stomach and maybe causing acid reflux. We generally recommend not eating a giant meal right before bed. I think a small snack can sometimes be fine. In terms of why we feel sleepy, I'll offer a hypothesis, and then maybe Gary can tell us the real reason. But my suspicion is that it has a lot to do sometimes with the timing. So a lot of times when people eat lunch and feel sleepy after that, there's actually a dip in our circadian rhythm in the early afternoon. So it might not actually be the meal. It might be the timing of when you're eating it, and we're associating it with the meal, but we have a dip in that circadian rhythm that's not propping up our sleep drive as much. So we tend to feel a little sleepier. Might also depend on the content of the meal. I know a big turkey meal is going to have tryptophan, which is actually a melatonin precursor, which can make you feel sleepy. Insulin responses to heavy carbohydrate meals can make you feel sleepy. I don't know, Gary,
I think
what
that you got a lot of it, and it's
yeah.
also just whenever the body will always prioritize blood flow, and so your brain is, your brain needs a lot of glucose in order to function. But when you're eating, so your stomach, your digestive system is now been turned on. So your body will prioritize blood flow towards the digestive system, which will then mean there's just less blood flow towards the other parts of the body. The brain always gets prioritized, for blood flow. The brain and heart, are always at the higher on the priority scale, but still there's going to just be more blood flow to that area. So it's going to be a bit less towards the brain, in addition to the insulin growth factor and the tryptophan and all those other, reasons that are going to just cause us to be sleepy. Um, and nothing like a good nap after a Shabbos meal. This is just part of this is, we all know that post-carb, tiredness.
Yes, that post-Shabbos nap definitely is very important. Thanks for answering that. And our next question is, why do people take melatonin if the body produces it for them?
Okay. So, there are certain times, like in addition to, menopause and the geriatrics, there are certain medications that definitely can influence melatonin secretion in a negative way. Prozac is known. Some beta blockers are known. So it depends on the what's going else is going on. Um, and we know that, like we talked about earlier, that a lot of mental health, conditions affect melatonin, or are fighting the body's own circadian rhythm. And so we're trying to readjust it. But this is that there's where that's why it's only meant to be temporary, because the body really should be, producing its, taking care of it on its own.
hmm Also, just kind of along those lines of you were speaking about hormones produced by the body and different drugs used to treat insomnia. Is there such a thing as treatment-resistant insomnia?
I mean, I know that even whether it's the sleep medications or CBT-I, even the best papers I've read, there's, for CBT-I, and Dr. Boland, you can correct me if I'm mistaken, but it's an 80%, and even the most optimistic, responses. There's still 20% of people that are going to be struggling, even with the best of, interventions. But I think between, having medications and, working with CBTI, that there is a lot of hope, for helping people figure out why they're having such trouble. In addition to the cover-ups of medication, or addressing the uh, better skills and habits that CBTI promotes.
Yeah, I would also add that it's very stressful and very anxiety provoking to have the inability to sleep continually for a very long time. And unfortunately, the thing that we need to have really happen is a reduction in that anxiety and a reduction in that worry, in order for sleep to sort of happen. And the thing I didn't talk too much about is that when people are trying to sleep, they're putting in a lot of effort to do something that your body should just be doing on its own. The body doesn't need our help to make us sleep, but we tend to believe, okay, well, if I'm not sleeping, then I need to work harder. And so when someone starts to feel like their insomnia is resistant, that amps up the anxiety, which is almost like trying to swim upstream,
Right.
So I think to Gary's point too, I've seen certainly people unfortunately not get relief from CBT-I, but then I've seen them have relief from sleep medication. So I don't think that there's a situation where there's not a treatment in the book, whether it be behavioral or pharmacological, that can't give them some relief. I'm also a big proponent of timing. Sometimes we try to sleep during a windstorm, it's like trying to focus on your sleep when everything in your life is so super stressful. Like sometimes we have to really think about doing things for the time being, and then maybe CBTI can be addressed when life is a little more calm. So,
Yeah, Dr. Boland, that actually brings up a good point with our next question about, using CBTI or using pharmacologic treatments. In both of those things, are there any aspects of insomnia treatment that differ during pregnancy specifically?
I'm sure there's things that differ in pregnancy as far as medications are concerned. So maybe Gary can, but there's been actually a lot of trials of CBTI during pregnancy. It's been shown to be effective. It's also, I think, effective at helping prevent postpartum depression to some degree. So certainly CBTI can be helpful when someone is actually pregnant. The one time that I tend to not want to start CBTI is actually during the first 3 to 6 months postpartum, just because of the nature of how often the person has to wake up to feed the infant. So when there are so many like built-in wake up times in the middle of the night, I find sometimes that's counterproductive with some of the strategies that we have for CBTI. So I would just try to work with the individual on bringing down some of the sleep anxiety, but like straight classic CBTI, that might be the only period where I might not jump to that as my first line treatment. But Gary,
And in terms of medicine, it's obviously we treat the first trimester different than we treat subsequent trimesters, with the not wanting to limit the exposure to the developing baby as much as possible. That being said, there's melatonin is definitely something that is we feel that is very safe. Benadryl is actually that is something that is it's a very safe during pregnancy. And so Benadryl has a use of being an antiemetic, so preventing vomiting for women that have hyperemesis. And so it is something that can be used, and that's during pregnancy. Again, under the guidance of your doctor, but it's something that we are not fearful of really harming the developing fetus. And pregnancy is the definition of a temporary reason that's causing insomnia that we please God. I know that once the baby is born, then there's an insomnia caused by the baby. So it's not that, and I know that in the frum world, Baruch Hashem, there's a constant and kids are around and pregnancies, there's a lot of that's going on. But that being said, I think that melatonin and Benadryl are really the mainstays of treatments. And then, if further medication, I really would just recommend you speak with your OB to get the best recommendations for how to address that.
Yeah, very interesting. Going back a little bit to the treatment-resistant insomnia question, there were a couple people wondering, are there some bodies that just resist sleep, and specifically like falling asleep, even if you're pretty sleep deprived, that they just still can't fall asleep? And also, this I think will be our last question, just in the interest of time.
I mean, I think Dr.
Lelonek.
Sorry,
It's okay.
I'm getting sleepy, so this is my brain starting to shut down. I think when you talked about the first part of the algorithm being like, let's get at what the cause is.
Right.
So I think that in a lot of the individuals that I work with, the resistance to falling asleep at night has a lot to do with cognitive arousal, meaning there's a lot of worry, there's a lot of trying to watch a pot boil. So almost trying to fall asleep while trying to see if you're falling asleep, which is like a process that really doesn't get anyone anywhere. So when I work with resistance, I don't see it as someone with an inability to fall asleep. I think sometimes it can be just a practice that has to evolve over time, like learning to bring down some of these anxiety provokers, learning to think about sleep a little bit differently, learning to just sort of allow wakefulness to be there without trying to fight it. But certainly I think, if there's other reasons that are not behavioral and not cognitive, right? We talk a lot, at least in the model that I used, about how insomnia develops. There are actually, biological reasons sometimes that people are not sleeping that really don't have anything to do with what's going on stress-wise. And I think, maybe Gary can speak to more of that, but, understanding what the root cause is, I think, is really important.
Right. And I think that we talk about like taking away the clock, when you have your digital clock and not like staring at the clock and waiting, watching it pass you by. Like we try to decrease much of the anxiety that is around sleep, and being aware that you can function, like even on the worst case scenario, you usually can function on very little sleep the next day, that it's, trying to decrease the amount of pressure that you're feeling to fall asleep, because chasing sleep is of just is like nidada shnasa melech. You're chasing after sleep. It becomes very hard to sleep when you're chasing after sleep. If we can help you just relax a little bit and take off some of the pressure, sleep then will become something that is catchable. But it's the act of chasing that by definition makes it almost impossible in that moment to catch. And that's what CBT-I and the medications, a lot of the medications are really about just helping a person relax in order to allow sleep to take its spot. And that's again the concept that the sleep is something that's allotted to you, and it's just creating a receptacle that can receive it.
Yeah, I definitely personally relate a lot to watching the clock and chasing sleep. So this was very informative. And thank you so much, Dr. Lelonek and Dr. Boland, for your time. This was very informative. And thank you so much, everyone, to coming to our webinar. We hope that this was educational and informative for you as well. And we look forward to seeing everyone at our next webinar.
Thank you so much for having us.
Thank you.